There's a fundamental problem today in the way we develop drugs. And if you can imagine a scale where on one side of the scale we have the needs of the lab and on the other side is the needs of the clinic. On the other side of the scale, the needs of the patient and the needs of the protocol. And there's this balance here. And some of the balance is very research-centric because we're in a research-centric business. It's what it's all about. And then there is this patient-centric. What are the real important needs and requirements of patient?
These very small things matter the most.
Ultimately, it comes down to a question of respect.
We've got to move from this perception of research as transactional, where it's all about money and profit.
There's a lot of good examples of patient-centric thinking.
So what can you do at the micro level? You can make sure that when they're in the hospital for 6 hours, they get lunch. You can make sure that, in Boston, it's very difficult to get around. It's a drag to drive, and it's a pain to park, and for many elderly patients, or for example, patients who have eyesight issues, it's very difficult to take public transportation. So in some situations, it may be getting them a car service. In addition, like I said, it's understanding their experience with the research and being willing to, in cases where it's okay, adjust the research to meet their needs.
One of the things that many cancer patients get are these MRIs, magnetic resonance imaging, or other radiographic images. And sometimes you have to drink this terrible stuff. And you've got to drink it over a period of time. And what they're contrast agents that are used to amplify what shows up on the MRI. And so a good example of patient centricity is that somebody came up with an idea of allowing patients to choose what flavor they wanted to receive this particular drink. So you can now get strawberry flavor or iced tea or lemon. And that's a classic example of patient-centric.
One of the interesting things actually that we're seeing now is trying to think more about the patient when you're writing the protocol. So when you're starting to write that inclusion-exclusion criteria, think about, hey, what if the patient gets a flu? Is that something that means that they can't be in the study? Because if you just say anybody with the flu can't be in the study, that's easy. But if you say maybe that won't affect how this drug's going to treat their disease, then you allow that patient population in, then you've made it easier to recruit subjects. So really, we talk about recruitment really starts at the time of protocol development. Finding patients really starts at the time of protocol development. And it's not only the inclusion-exclusion criteria, it's the requirements.
We've got to educate people about the intent of the people who are right at that center caring for them. That it's not about a transactional process, that we really have them at the center of the process. Research really is about health and public health. Human connection is not efficient. It takes time, and we've got to reestablish that connection, and we've got to maybe slow down the pace to make sure patients feel as though we're putting them first, we're listening to them, we're answering their questions, and that they feel that they're not just first in our scientific minds, but they're first in our hearts.